But let's turn to what this actually means in practice. What would you say are the distinguishing features now, Charu, that will lead you to favor one treatment over another, both in the non-squamous and the squamous population?
So I think I would, as before, what hasn't changed is that I still look at histology. I think histology still drives treatment selection. I think getting a sense of what mutation may be driving a particular patient's cancer is still important. But for those patients who don't have any driver mutations, and I think triplet is very relevant, be it any histology now, squamous or non-squamous, we have data to support triplet therapy for both. However, I will say that even though some people may write off PD-L1 now and say, well, the benefit is for all PD-L1 subgroups, why do you even need PD-L1? I will still say that PD-L1 is important because there is that subset of patients with really high PD-L1 expression, above 50%, where if we go back to the 024 data, can we just use pembrolizumab monotherapy and perhaps spare them the nephritis or the neuropathy that may accompany some of the doublet chemotherapy added to the pembrolizumab? And then again, in the same vein, I think for the PD-L1 completely negative, the zeros, I mean, data from TMB as well as CheckMate 227, are there some patients where we can, spare chemotherapy, perhaps just use IO combination or, just not give them immunotherapy? So I think we still have questions at both ends of the spectrum, but really, clearly, many more treatment options for our patients now.
My view is that we're increasingly in a world of, for at least the patients without a driver mutation, you're giving pembrolizumab, and the question is it with or without a histology-appropriate doublet? For the high PD-L1 group, I would say the data are very strong with either choice, but in a patient in whom I don't feel an urgent need to give everything up front, and those patients where I would still try to front load, it would be those with very rapidly progressing disease, becoming increasingly symptomatic, losing weight rapidly before you start them, or the ones who have had marked progression between their initial ER CT scan and the PET CT you got to finish staging 3 weeks later. Those are the ones who I'd try to give a combo up front and just give everything you've got, because even with monotherapy, the response rate's 45%, not 90%. But for a lot of the others, if you can spare them the toxicities and the other challenges of chemotherapy for a long period of time, when it may just be along for the ride, I would rather do that and spare the chemo doublet for later. But for the lows and the negatives, most of those, I would be most inclined to give a combination with either the Keynote 189 for the non-squamous and the 407 regimen, one of the taxanes for squames. What are your thoughts here?
I think I really want to emphasize what Charu just said, that we still need PD-L1 testing for all of our patients. We still need it, and we still need mutation testing. We still need to understand which patients have EGFR mutations. We still need to find those with ALK-positive lung cancer, because the treatment really depends on knowing these things for all of our patients. So I think this is something we can't let our enthusiasm for combination chemotherapy, immunotherapy, regardless of PD-L1 status, while it's a huge accomplishment, we still need to pick our patients. We still need to be good doctors and find the right therapy for the right patient.
Yeah, you make a great point that we wouldn't want to just say, you don't even need to think about it anymore. Give your platinum doublet and immunotherapy, you're never going to be wrong. Yeah, that it still is valuable to distinguish who might be most likely or least likely to benefit. And another thing that was not a featured presentation at ASCO, but is worth thinking about, is the group from UCLA reporting their results in a very small study of giving first-line pembrolizumab to high PD-L1 patients with an EGFR mutation instead of first-line EGFR inhibitor, and showing horrible results, that none of these patients with a proven EGFR mutation responded, and 2 of 10 died in the first 6 months, which is very unusual with this, and really suggesting these are not the same patients, and we shouldn't take shortcuts and not do the testing for these patients who are going to be much better served by doing targeted therapy first. Doesn't mean you would never give immunotherapy, but one of the toxicities was a pneumonitis developing on erlotinib after discontinuing pembro, just highlighting that the sequence may matter.